Hello, my name is Arthur Kleinman, and I'm an anthropologist and psychiatrist who works in global health. Today, I would like to talk briefly to introduce a concept, method, and perspective. The idea is social technology. The way I use it is social technology for global aging and elder care in China. So I'm a China scholar, but what I'm going to present today, although illustrated in China, is meant to be applicable globally. So the idea of social technology is putting together what would seem like apples and oranges. Anthropologists, engineers, design experts, global health experts, physicians, and indeed others, such as business experts. The purpose is to improve care. So the central focus is on providing better care. This approach challenges a major persistent distortion, in my mind, in public health, which is to separate prevention and care. From the social medicine perspective I'm presenting, prevention requires care, and care requires prevention. Now, with regard to the elderly, and specifically in China, but it could be anywhere in the world, problems of limited mobility, of falling because of problems in balance, of difficulty in understanding related to early cognitive change, of emotional lability and barriers such as depression. All of these issues can be addressed through a combination of biomechanical and social interventions put together that really, in a way, require each other. And this means, for example, in our work, having anthropologists together with design experts and engineers and health experts right at the beginning, planning interventions, working on the method of that intervention, but also on the expected outcomes and what is required in social settings and historically contextualize local worlds for those interventions to be successful. So let me give you an example that doesn't sound so highfalutin in terms of abstract ideas. Some years ago, my colleagues in China and I brought to elderly women in the urban context in Shanghai, women who were in their 80s and 90s living in high-rise towers with their families, usually a son and a grandchild and a daughter-in-law. We brought an assistive technology that was brilliantly developed by a Harvard engineer. And this is basically an exoskeleton made of what looks like thick pants with very specific kinds of bands crossing joints, and a motor and battery, and showed them in film how this assistive technology could help someone post-stroke or with Alzheimer's, early on Alzheimer's disease and balance problems, or with Parkinsonism and difficulty walking, to have a better better mobility, to have a better gait, as we say, to walk without falling, to be able to get from point A to point B. And the response of these elderly women was, these are fantastic. These are wonderful to look at, but we would never use them. So the engineers were astonished. How can you say that they're great, but you would never use them? And the reason that they said that, said the elderly women to us, was that so dangerous is it to cross a street in Shanghai because of all the cars going and the like, that they would never feel adequately emboldened with an exoskeleton to get over their fear that they would be too slow crossing the street and get hit by a vehicle. But they said, although we're not so interested in this technology, we would be interested in technological assistance in a problem that we take to be most at stake for us, that means the most to us. And that problem, they said, is that we have 5 or 6 friends in the same condition, our age mates in the 80s and 90s, in nearby residential towers, who are also stuck in their apartments, and none of us can get together. And if you could figure out, they said, a means for us to get together once a week, to be able to go to a tea house and have a good time together, it would so change the quality of our life. It'd make the difference between a good life and a not so good life. And so we said, wow, that's it. That's the question. How would you do this? And not just for 6 people, and not just for 60 people, and not just for 600 people, but for 6,000 elderly or 60,000 elderly. And that's one of the things that we're working on today. So beginning in this approach with what we would call an ethnographic analysis. That's a fancy term for what anthropologists do, which social anthropologists, which is to do a survey of what the local world is like. So for the elderly, what are their opportunities and their obstacles? Where are the problems that they identify? What do they want done about them? And then to work together with design people, engineers, public health people, to develop the interventions and to generalize those interventions. So some of the things that we have underway today, some of the projects, are introducing into China a more feasible form of palliative care. Now, palliative care, which is so important at end of life for control of pain, has a number of obstacles in the Chinese setting. So how do you deal with end of life pain, say, in cancer patients, and also deal with this fear that's of addiction, which means that the government severely limits the access to, say, things like morphine and other opioid analgesics. And one of the design and technological interventions here is to create a lockbox. I can't go into all the details with it, but it is one way to begin to address this problem. On the other hand, another issue with palliative care in China is the difficulty of talking about death and dying at end of life because of the fear in Chinese society that somehow this will be self-reinforcing, and talking about bad things will bring them about. And this is called buhaoisa. You shouldn't talk about this. It's embarrassing, humiliating, not appropriate. So changing that cultural value system, that sensitivity, can actually be done by work in communities and in families in order to support a useful palliative care approach. Well, I don't want to give any more examples because they would go on and on into what we're working on, but I want to suggest that for social development projects in the future, there are certain lessons to be learned from him. One is to begin working with the community. The community must be accompanied, not led by outsiders. The whole idea of accompaniment is that the community itself has the knowledge and the capabilities to conduct interventions that will improve social life, and they must take the leadership in this. So the technology must fit into that context in a culturally effective way. Second, that the technologies themselves need to be so related to the social circumstances that they make sense for being used, and that we understand what might be unintended consequences or simply the road to failing and prevent that. Third, that from the first, social scientists and engineers and design people and health people work together. It's not like everything is planned by the engineers and the health people, and then the rest are brought in later. But from the very start of the planning process, conversations must lead to what the appropriate outcomes were with the communities, deep involvement. Along the way, we learn certain kinds of things, that people live in local moral worlds. Engineers produce things that are going to be used in those local moral worlds, where emotion and value are critical and may not be the same as what the provider of those interventions is thinking about. And the last point I want to make is the focus on care. That all of this gets united by a central value for the providers, for the recipients, of care, not control, not intervention for intervention's sake, not social development for social development's sake, but social development for care, with care as its principal focus, and the very method of intervention itself being a care-full one filled with care. That idea, that care at the center, is what has made our collaboration work. Thank you very much. It's a pleasure to speak with you. And if you have questions, please don't hesitate to send them my way.